Thank you. All right, so I'm going to take the pro side that thiopurines still have a role in the management of pediatric IBD, and these are my disclosures. Once again, this thing's not working. Bob, did you do that? Okay. These are my disclosures from the last 12 months, none of them related to thiopurines. So I think, as you all know, we have a balancing act in pediatric GI, as do our partners, especially true in IBD. And on the one side, we want to control the patient's disease, and on the other side, we want to minimize medication side effects. And this whole debate is really about that benefit to risk ratio. So I'm going to start with the points against thiopurines that Dr. Baldessano might bring up. Biologics are more effective, I'm conceding these, at inducing remission in Crohn's based on the SONIC trial. Biologics can rescue a subset of patients that don't respond to thiopurines, and thiopurines are associated with an increased risk of lymphoma, especially in adolescent and young adult males, and also in patients on combination therapy. However, I still use thiopurines, and here's why. Number one, they work. They work as monotherapy in Crohn's, monotherapy in ASA refractory ulcerative colitis. They're highly effective in combination with biologics in both Crohn's and UC, and they are also effective in preventing post-op recurrence. Bad side effects are rare. Biologic side effects are no bargain either, and you don't get antibodies to thiopurines. So this is a classic study now, the randomized controlled trial done by James Markowitz and colleagues that compared 6-mercaptopurine to placebo in newly diagnosed Crohn's disease. And if you look at the graph on the right with that survival curve over there, the top line is the thiopurine line with the fraction in remission after 600 days, and the lower curve is those on placebo. And what he found was after 18 months of treatment, 9% of 6MP patients versus 47% of controls had relapsed. No question these drugs work. Now, are they this effective? I personally do not believe they're as good as this particular study, but there's a newer study done by Brendan Boyle, on which Dr. Baldessano is a co-author, from the Improved Care Now Consortium that looked at 65 patients in different practices. And look there, a 69% remission rate within 180 days of thiopurine initiation. And if you looked at 1-year follow-up, a 42% steroid-free remission and a 23% continuous steroid-free remission. If you look at biologic data, it's not that much better than this. They did emphasize, however, that it's not as good as Markowitz, and why not? Well, you're not in a clinical trial. There's variability in dosing, there's variability in drug metabolism and levels, and there's also non-compliance, non-adherence. However, they still clearly work. Now, I will concede we need more data on thiopurine mucosal healing in children. But here's an 8-year-old Crohn's colitis patient I have before mercaptopurine on the one side, and then on the follow-up side on the other side, 2 years later, you can have full mucosal healing. And this young lady who started now is at age 15, full clinical and endoscopic remission ongoing. So again, they work. Now, Dr. Baldessano is probably going to tell you about this study from the risk population that compared anti-TNF versus immune modulators versus other treatments by Tom Walters and colleagues. And what Dr. Walters did was he looked at the people in the risk group. 68 of them got early anti-TNF brought in by their physician. 248 got early immunomodulators, and 236 got no immunomodulators. He then used something called a propensity score. That's a statistical fudge to pick 68 equally sick children from the bottom two groups. So 68 from that immunomodulator group, 68 from the no immunomodulator group. And of course, he was able to show that if you pick the sickest children out of those two studies and match them, the anti-TNF group had better outcomes. Does that mean every child with new onset Crohn's needs to be treated with biologics from day one? No. To quote Dr. Walters, further data will be required to best identify children most likely to benefit from early treatment with anti-TNF therapy. Not everyone needs an anti-TNF day one. Maybe we can find good ways to pick out those 68. How effective are thiopurines in children with ulcerative colitis that don't respond to aminosalicylates? The Pediatric IBD registry from Jeff Himes and his group looked at 394 newly diagnosed UC patients. 194 of these were treated with thiopurines within the first 3 months of diagnosis. These were salicylate failures. If you look at the one-year outcome in the 133 patients treated with thiopurines that were followed for 1 year, 73% avoided infliximab or surgery, 50% had corticosteroid-free inactive disease. So thiopurines work in Crohn's and they work in ulcerative colitis. Thiopurines also reduce colorectal cancer risk in adults with ulcerative colitis and Crohn's disease. A beautiful French study by Beaugerie and colleagues following 486 patients with active IBD. They selected about 3,000 of them that had high-risk colitis, both Crohn's and UC, involving more than 50% of the colon and more than 10 years of disease. And then they looked and saw who got cancers. Read that bottom line. Patients on thiopurines had a much lower likelihood of getting cancer, a hazard ratio of 0.27, or your cancer risk reduced by 70% in this study. Now, what about combination therapy? We know about SONIC. In SONIC, you have azathioprine and infliximab, 57% remission. Infliximab alone, only 44%. But here's the key. Antibodies to infliximab, 1% in the combination group versus 15% in the monotherapy group. Antibodies, as I'll show you tomorrow, correlate with loss of response and all kinds of other problems. Another study recently came out, the SUCCESS trial, looked at the same thing in ulcerative colitis. And if you look at the 16-week remission rates, azathioprine and infliximab, 40% remission, infliximab alone 20%, azathioprine alone 23%, and once again, low rates of antibodies in both groups. Combination therapy, more effective than monotherapy. Now, what about methotrexate? Data on methotrexate is quite limited in children, especially as the first line in new onset pediatric Crohn's. Most of our studies are on 6-MP non-responders. A nice study, however, done by Dr. Delandre in Montreal looked at one-year remission rates on methotrexate in children, and it was about 25% in Crohn's, 13% in ulcerative colitis. We like to use methotrexate because we think it's safer. Efficacy is lacking. In the COMMIT trial in adults, no difference in remission rates between infliximab monotherapy and infliximab and methotrexate. Unfortunately, we need more data here. What are the risks of these medications? The risks of thiopurines have been described for the last 30 years. We know about pancreatitis, leukopenia, infection. We also know about lymphoma. There's one pediatric study on the risk of lymphoma in thiopurines in children, and it's our study from Boston Children's. Laurie Ashworth, the first author on the paper, went through 1,500 charts and calculated all the duration of exposure to thiopurines. We saw 2 lymphomas in 30 years. We calculated the risk was 1 lymphoma per 2,221 patient years if you're on a thiopurine. What about anti-TNFs? Infusion reactions, anaphylaxis, opportunistic lung infections, interstitial pneumonitis, psoriasis, hepatitis B reactivation, demyelinating disease, and loss of response. The point I'm making, anti-TNFs, no bargain. These are real serious problems that we see with these drugs. So, in conclusion, thiopurines work in many patients with moderate Crohn's, ASA refractory UC. Data on methotrexate is limited in children. Serious adverse events do happen, but are fortunately rare. You can always add a biologic later, a few months later, if they don't respond. You need to think about combination treatment. I'm going to talk about that more tomorrow, but you need to weigh the benefit to risk ratio of that, at least a short course. And lastly, don't let the boogeyman scare you. We have had these kind of medications for the last 30 years. They're pretty safe. There's no reason to give up on them. Don't let the boogeyman scare you. And I turn the podium over to Dr. Baldessano. And in honor of this debate, Dr. Baldessano, I did buy you a T-shirt, actually, to commemorate the event. What is it?